we will discuss about management of hyperkalemia, that is serum potassium concentration of 5.5 milliequivalent per liter. The first measure is cardioprotective measure, in which there is an immediate antagonism of cardiac effect of hyperkalemia. We give calcium gluconate 10 ml 10% slow IV over 10 minutes with cardiac monitoring. It raises the action potential threshold and reduces the excitability without changing the resting membrane potential. The effect starts within 1 to 3 minutes and lasts up to 30 to 60 minutes. The second measure is rapid reduction of plasma potassium concentration by redistributing into the cells. The first measure is regular insulin 10 units with 100 ml of D25, that is 25 grams of glucose. IV infusion is given with plasma glucose monitoring. Nebulization with beta agonist is also done. Bicarbonate, it is a slow acting drug 150 milliequivalent in 1 liter of NS or D5 IV given over 4 to 6 hours. Now the third measure is removal of potassium from the body. Sodium polystyrene sulfonate. It is a cation exchange resin. It exchanges sodium for potassium in GIT and increase fecal excretion of potassium. 15 to 30 grams powder in sorbitol suspension every 4 to 6 hours. The peak effect starts at 24 hours. But there is a risk of intestinal necrosis. There are the new novel intestinal potassium binders. They are preferred over sodium polystyrene sulfate as there is no risk of intestinal necrosis. Hemodialysis is a most effective and reliable method. IV saline may be helpful in hypovolemic patients. Loop and thiazide diuretics helpful in volume overload patient with sufficient renal diuretic response.